I lived in Dallas for 7 years, and it's great to be back in Texas. We wanted to start, I think, just talking a little bit about Callan from our perspective. Chaz shared his story. The scan on the left here is what Callan's chest looked like when we first met him. We can see if we can make it play here. But this is a CT scan, and what you'll see is the normal lung over here is dark, and this is the tumor that filled this half of Callan's chest. And you'll see it's pushing on all these important structures here. These are the major blood vessels that go to and from the heart, the blood vessels that go to the arm, the nerves that go to the arm.
It's not subtle.
Sometimes I'm trying to show patients heart scans. This one it's easy to see where the tumor was. And this is a big challenge. And I think I left Texas to go back to CHOP, and part of what made me make that move was the opportunity to really work with all the other team members that are there, including Stephanie, Dr. Fuller, but all the team members, the radiation oncologists, the other surgeons, the CT surgeons, the orthopedic surgeons for other types of tumors. We were talking about osteosarcoma earlier. And I think really being able to assemble that team with the expertise on the pediatric side, and also partnering with the adult doctors on the adult side who take care of adults with lung cancers and other types of tumors in this area, but that help the surgeons make a plan for how to attack this. Is really amazing and unique, and what brought me back to CHOP. And so I was fortunate to get to meet Chaz and Callan and talk to them and help guide some of this therapy. But really it was Chaz that drove this, and Callan who drove this forward. And it's great to get to see Callan now. He came and picked us up at the hotel today. Great to see him in college.
He's right there.
You can't see him there yet. He's hiding. Where are you, Callan? Tumor-free now more than a year from finishing therapy. So really excited. And Stephanie, do you have any thoughts about this sort of?
Yeah, I would say my first introduction to Callan was from one of our general surgeons. And this is the first link that kind of pieces us together. I was the kid in school who always got taught I talk too much, and I'm really grateful for that because it made me a connector. And being a connector, I think, is one of the most powerful things you can do in medicine, because it gives you the potential to know exactly what your limits are, but to think so widely and so globally about the fact that if you put the right people in place, you can make anything happen. And that's what happened. Is Pete Matei, one of our general surgeons, reached out to me. He's like, we've got this really big tumor. I'm not sure I can do this by myself. I credit Pete Matei for saying that. I am, by training, a heart surgeon. I operate on babies who are born with holes in their heart, half a heart. That's the mainstay of my treatment as part of that. Gratefully at Children's Hospital of Philadelphia, we offer a broad spectrum of surgery. So I do heart and lung transplant, and I end up doing a lot of the central airway work that's really complex, and the general surgeons don't feel comfortable with, because a lot of it requires the use of heart and lung. And so when Pete reached out to me, it was, we need somebody who has more expertise in dealing with this than I do. And as soon as I looked at it, I said, wow, this is going to require a lot more people than just me and Pete. And then the next synapse, the next connection happened, which was reaching out to orthopedic surgeons, neurosurgeons, vascular surgeons, and people who operate in silos. We see each other in the halls. We see each other at Christmas parties. But we don't always operate together. And what's even more important about that is that we're bridging two institutions, an adult hospital and a pediatric hospital. And fortunately, I operate on some adults at the adult hospital right down the hall from the vascular surgeons. So when I was able to phone a friend, so to speak, I think it really paid off. And Chaz has a picture, which is the right upper hand corner of my whiteboard, which is a chart with dates and listing all the people I need for the surgery and check marks next to who's available on what day, and putting it together, and another list running diagonally of all the studies I needed and everything I needed to get this done, who was available to do it. And the fact that you operate across the street was like, good, I can push through your privileges in 2 weeks for you to be here and do this operation. And the fact that you're out of town, good, when are you in town? When can we orchestrate this around his radiation and his chemotherapy? And it became a tremendous gift to be able to pull these resources together. And that would have never happened without Ted and Pete, who made those first phone calls to me. I had honestly never even heard of synovial sarcoma. The first phone call I had with the Spences was pretty intense. Sorry, Chas. Laura, you were lovely. Where's Laura? But it was a phone call in which I felt like pretty much every answer I had for them was, I don't know. Can you take the tumor out? I don't know. Are you able to spare his brachial plexus? That's the branch of nerves that come off his spine that give control to his right arm, which is really important for somebody who's as talented an artist as Callan. My answer was, I don't know. My question was, what if I can't? Callan's answer, I can learn to draw with my left hand. When you have the kind of odds against you that are, if we don't get this out, he's got no chance, those are the kind of odds I'm 100% in for. Because either you give it a shot, and you come out successful, or you give it a shot, and that's the best thing you can promise anybody in medicine. There are so few guarantees for what we do, so few guarantees. But I'm gonna try my best, and I'm gonna do the best I can, is the first guarantee I give people. And that's what you were able to do for your family.
Can you talk a little bit about radiation oncology at Dr. Hilkeiser?
Right.
Another connection.
Another connection. So Dr. Hilkeiser is someone we work very closely with. She's a dedicated pediatric radiation oncologist who works at CHOP and works at Penn. And again, spans this divide between the pediatric and the adult hospital. So she was Callan's radiation oncologist. She only takes care of kids with cancer, but again, because she works with the adult radiation oncologist at Penn, has the ability to both sort of have this pediatric expertise, but also partner with the adult doctors. She's treating a patient of mine who has melanoma right now, which is a very rare pediatric cancer, but a much more common adult cancer, and so is able to bring her pediatric expertise, but work with the melanoma specialists on the adult side. I think it's that sort of, again, those connections, that ability to partner that we all do through our tumor board at CHOP, and now through all of your generous support and the Spences, the National Tumor Board as well, to bring all these people together, locally and nationally, to try to advance care for each patient and try to be able to offer every patient the best we can today, and hopefully make things better for tomorrow. Next slide. So Chaz showed you his presentation, an updated version of what you showed me when we first had that meeting, and I still remember how impressed I was when Chaz gave his talk. It was like a talk at a medical conference, and Chaz is not a doctor.
I play one on TV.
Very well.
My dad was, my granddad was.
It's genetic, so you're in the club. But I was really impressed with the amount of number of patients, first of all, but the amount of data and the way Chaz has been able to synthesize that data, and really thought this was a unique opportunity to study this rare cancer. Right? So synovial sarcoma is very rare. There's only a few hundred people a year in the United States diagnosed with this tumor. It's especially rare in adults, right? In adults, there's much more common cancers like lung cancer and breast cancer and things. In children and adolescents, sarcomas are more common. So they're about a quarter of the tumors that happen in children and adolescents. So we see them more, but even for us, individual types like synovial sarcoma are rare. And I thought this was really an amazing opportunity to gather data from all of these patients and be able to advance the field, to answer questions like, when should you give the chemotherapy, before or after surgery? Chaz had thoughts about that the first time we met. And supported by data, not just like thoughts. And that's something that, as Chaz mentioned, can't be a change even at a big center like CHOP, because we don't see hundreds of those patients to gather that data and understand. And so, with the support from the funding that you all raised, we were able to put together a protocol that went through the regulatory process so that we can officially use the data for medical conferences and publish it in medical journals, and recruit a project manager to really help enroll patients and manage the data, gather all this data, look at the medical records and input that data into a database so that we can use it to answer questions like Chad showed you. And that protocol has now been approved by the IRB, and we've started recruiting patients. As of last week, we've had 42 patients enrolled, and continuing to grow, and have sent requests for 62 different sets of medical records from different hospitals across the country. If you go to the next slide, you can see that this really does span the country. As we're growing here, there's certainly representation from Texas and Pennsylvania, but it really spans, many states across the country that we've been able to gather this information, and hope to continue, of course, to grow this across the world as well. Next slide. So this is what we've gathered today. We've just started the process of gathering the specimens that Chaz was talking about, taking the tissue in. And again, the goal is to be able to let researchers use this tissue, including us, but other researchers as well, use this tissue to learn more about this disease, to find new treatments, to understand better which patients need more or less therapy, and use that information to improve the care we're able to offer for patients tomorrow. So next slide. So I think this part of the project is moving ahead very quickly, and we're really excited about that. The next steps that we're working on with the funding that you already have generously contributed include international recruitment. There's some regulations around consenting patients in other countries that we're working through, and need to partner with local oncologists in other countries, which we're doing to move this forward. We're starting to collect these biospecimens, and we're going to start doing genetic testing on the specimens to understand the causes of synovial sarcoma at a genetic level, and whether there are ways that we can better identify which patients need which therapy, right? So synovial sarcoma is caused by one genetic change in all patients, but it's a different disease in different patients, right? Some patients have small tumors and they have surgery, and the tumor never comes back. Other patients have large tumors like Callan that are more difficult to treat, but can get chemotherapy and surgery, and the tumor never comes back. Other patients, it spreads, and we don't understand why those differences are, and being able to understand that could really contribute to identifying the right therapy for the right patient, and not putting people through all the treatment that Callan went through and Solomon went through if they don't need it, but at the same time giving more treatment or better treatment to those patients that need those kind of therapies. And then sharing the data, right? So we're partnering with what's called the D3B, which is the Center for Data-Driven Discovery. And what that is it's a group that shares the data anonymously using the Amazon cloud, really so that researchers across the world can look at the same data and study it, right? Our goal is to improve outcomes for this disease. It's not just to develop data that's housed at our center. And really by sharing this data, different researchers with different ideas can attack the data in a different way and try to learn from it. And we'll share the genetic data, we'll share the data about the patients. It's of course all de-identified, so people won't know who's Callan in that data set, but they will know what happens to all of the patients so that they can learn from it and we can learn together. So next slide. As Chaz mentioned, we were really fortunate to be able to start this synovial sarcoma tumor board, which is held once a month right now. It started in July of this year. We've so far had 54 members join the tumor board. It includes radiation oncologists, surgeons, medical oncologists. We've had pathologists join to share unique features of different tumors, and sequencers, genetic testers to talk about the genetics of the tumor. And we reviewed 2 or 3 cases presented by different physicians who come with a question to talk to the group about how to manage the patient, or what are the options when the tumor does recur, or how do we treat these patients at the very beginning. And patients from anywhere can be presented. Next slide. And so here's the distribution of the tumor board members. So these are the physicians that join the call. And you can see again, there's representation, of course, from Texas and Pennsylvania as the home of this effort. But there's representation really across the country and across Canada. And we hope to enable people from other countries as well to join. Next slide. But it's been really fascinating to me to see what we talk about on these tumor boards and to learn what is the same and what is not the same in the care of patients across the country, right? So just this last week, we had a tumor board and we're talking about the initial treatment to synovial sarcoma, which I had thought was fairly standardized across the country, but it turned out there was actually more variation than I thought in terms of which patients get chemotherapy, which patients do not. What that chemotherapy is, what the doses of those chemotherapy medications are. And I think being able to share these ideas and share outcomes together really is critical. Talked about surgical approach to difficult patients. We've talked about treatment options at recurrence and clinical trial options. People have come to present their clinical trials to the group of doctors so that they're aware and they can offer those to their patients, even if the patients may not be at that center. And how, as Chaz mentioned, how do we follow patients over time to make sure that the tumor doesn't come back, or if it does, so that we can detect it early and intervene in the most appropriate way. And I think one of the biggest things this has done is it's really starting to foster this community of pediatric and adult doctors that study and take care of patients with sarcoma. And that way we can all be connected together and share ideas. So it's these connections, not just at CHOP and not just at Penn, but really across the country to reach out when someone has a difficult case of this situation to talk about what your experience was, or talk about a clinical trial, talk about different ways that we can manage these patients. So next slide. And these are flyers, so if any of you have patients that are not yet joined the registry, there's a QR code here. Please feel free to sign up. We would love to continue to recruit patients, and are happy to talk to you if there's any questions. Next slide. So as Chaz mentioned, thinking about where do we go from here, and I think we really have some opportunities to do additional profiling of the tumors as they come into the biospecimen repository, to look for those biomarkers that I mentioned, to identify new treatment targets, to develop additional models in the lab. One of the challenges with rare cancers is there aren't very many different ways to test it in the laboratory because there's not very many models to test it in the lab. And what that means is that the pace of discovery is slowed because you can't take different treatments and try them in hundreds of different models in the laboratory to see which ones work, like they do for breast cancer or lung cancer, and where we've made some progress. So developing these living models of the tumor in the lab can be really critical. Testing new therapies in the lab, and we've just been talking about that with the Spence, and they're working to raise funds to do some testing in a mouse model that's been developed with our collaborators at Penn to look at immune therapy for synovial sarcoma and a different way to block one of the genetic changes of synovial sarcoma. And then putting together a conference actually for patients and physicians together to come and share the research, but also share that research both at an academic level between physicians and also with patients and their families to understand new treatment options and where things are. This has been done for Ewing sarcoma. One of my colleagues, Dr. Grohar, who's working on this synovial sarcoma work with us, leads a conference like this for patients with Ewing sarcoma and physicians with Ewing sarcoma. And it's really created, again, that community so that people are talking and people are connected and that we can move ideas together forward and take different approaches based on each individual's expertise. And then I think Dr. Foley is going to talk about a potential clinical trial of a new treatment or new medicine called Tumor Glow that can help us identify tumors during surgery. But really the goal is to make this sort of virtuous cycle, right? Where we take the specimens and data from the registry and biospecimen repository, we profile them, we test new treatments in the lab, they lead to new clinical trials, and that leads to more data and specimens so that we can continue to advance the field. And really developing this community, developing these connections, I think is what's going to make that possible. So I'll let Dr. Fuller talk about Tumor Glow for a little.
So as if that wasn't enough, these are some images of a thoracic surgery. This is a video-assisted thoracic surgery. And it's pretty obvious in this picture. You can kind of get an idea where that lucency is, that's potentially a tumor. But what's really nice is if you apply cyanine green to it, you can actually see exactly where the tumor is in a patient. And this was originally developed for sarcoma. It was a technology that was abandoned for sarcoma and instead used for colorectal metastases because there were so many more patients with colorectal metastases than there are with sarcoma. It works virtually for any type of metastatic disease in the lung. So this is the advent, my partner over at University of Pennsylvania, Sunil Singhal, who's the Vice Dean of Research for University of Pennsylvania. Really impressive guy, very soft-spoken, very kind, has operated on a number of my friends. And he basically spent the last 15 years inventing this. Patients come in the day before surgery, they get an injection the day before surgery that is basically this dye. It leaves every other tissue in the organ within 24 hours except for cancer. And the reason it uptakes in cancer and stays in cancer is because the very high metabolic rate keeps it alive in those cells, essentially. And what you can do is identify where there are potential metastatic sites in the lung using this. And again, it's never been trialed in sarcoma and it's never been trialed in pediatrics. And this is where I want to bring it to pediatric patients. We know that we are so dependent on R0 resection for these patients, and we know we're dependent on getting rid of the lesions. Imagine even if this is useful for extremities for sarcoma, if we could know and feel reassured that we got all the tumor out at the first operation. If we could feel reassured that we got all the sites and metastases out at a second operation, how much more that would benefit our patients. So when Sunil initially trialed this, the second advantage for this is it shows you basically margins. So this is a tumor that he thought he had completely resected. You can see that's a staple line across the lung, but you can see the green exiting the staple line. It's right on the margin. So this was a tumor that he thought he had completely resected, 100% resection by palpating and feeling it. And
How do you know? Sight, feel?
This is the only way we can tell a tumor exists is by either touching it or seeing it. And this allows us basically, it's like Superman vision. You know, we can go in and with this across the staple line, he could tell that he did not get the whole tumor. And he was able to go back in the chest and he was able to perform a wider resection and take more tumor from this patient.
Instead of having another surgery.
Instead of having a recurrence again. So instead of leaving tumor behind, it's like you want to leave no man behind.
Who's funding
This
this
is the
right
idea.
now?
This is Sunil Singhal. The first trial was an NIH trial that he did that was completely funded by the NIH. So this is one of the biggest problems we have in pediatrics. Is basically there's so little funding for pediatrics in the NIH. The majority of the funding goes towards adult medicine, which is really difficult. It's very challenging for us as researchers to be able to get, particularly surgical researchers, device development, and for good reason. There's a lot of stringent criteria involved in when you're quote unquote experimenting with a child. And this is considering, basically it's considered experimentation. But we know it works in adults. So then the question begins, okay, are we just gonna extrapolate its use and use it as a non-FDA approved use in pediatrics, which is possible. The issue with that is it still requires funding. So no matter what we do in pediatrics, even if we use this off-label, we have to be able to track it, we have to know what our results are, we have to be coordinators to enroll to enroll patients, we have to know details about surgery, we have to know absolutely details about post-operative care. And I'm not talking about over the next 6 months or the next year. What Ted and I have been talking about is, does this impact survival? If I am able to feel reassured that we got every little bit of tumor left in the chest, I want to know that that makes a difference to a kid's survival. And that's what we're hoping to do with this.
Well, at what level can you will the dye show up at a cellular level?
So that's a really good question. So the dye, the one thing that we're not 100% sure is depth of penetration. For example, a lot of these tumors happen to be peripheral in the lung. So you can see them because they tend to be in thinner tissue that tend to be on the margins of the lung. We don't know exactly in the depth of the lung how much we're gonna be able to see until we do the study. So what's the depth of penetration for the dye? We don't know for sure. Oftentimes though, I will tell you that if they are larger tumors, we'll be able to see them on CT scan. And I have a little bit of data to support that. So here are the patients who were trialed. These are all patients, 30 subjects in the initial NIH trial. So again, a small study. We're not talking about a huge study here. This is what got this FDA approved, 30 patients, okay? There were 53 metastases on CAT scan, the number one way that we survey patients for metastases. Every time Callan comes to CHOP, he has a CT scan. Of those, 10 were open, 20 were VATS, video-assisted thoracoscopic surgery, a couple small incisions and a camera stuck in the chest. In these patients, 7 additional metastases were found using the dye, 7. 4 additional metastases were seen on VATS. Okay, that was standard of, those were standard of care just from the technique of looking and finding. Now if you add the dye to it, an additional 3 metastases, 2 more patients who had metastatic disease taken out. And on top of that, 8 more patients who had metastatic disease taken out in the VATS group. Okay, so our eyes are only but so good at looking this. If you look at the additional 24 metastases that were found, that could have potentially been life-saving in these patients. This is one of the things that we're looking towards doing, and this is one of the studies we're looking towards doing. Sunil Singhal, who's my partner at Penn, is 100% on board with the pediatric trial. We want to run it between CHOP and University of Pennsylvania. We want to have the funding go exclusively to these 2 sites for approximately 15 to 20 patients for enrollment, and then we roll it out to every other pediatric cancer center in the U.S. to give them the option of participation. And if this works, I guarantee this is going to change the game.
That's awesome.
Ted doesn't want to hear me say that. He's like, don't promise anything.
No,